Hello, and welcome to the next in line presentation for the Transitional Care Nursing course. My name is Angel Smothers, and today we're going to be talking about different interventions that the research shows are effective for the faith community nurse to use in their practice to improve outcomes and prevent patients and congregants from returning back to the hospital. One of those evidence-based effective parts of what we can do is a medication review. And, the medication review really is important because one of the number one, if not the number one reason that people end up going back to the hospital is because of issues related to their medication. And so oftentimes people will not understand the discharge instructions and they end up taking the medication in a wrong way, not taking the medication at all, or taking too much of the medication. So it's important for the faith community nurse to do a medication review to make sure that everything is in alignment with what the orders were at discharge. And really to also assess, are they able to fill their pill box? Do they need help with that? And so forth. So medication management is a big part of what we do in transitional care. And, medication mishandling by systems of healthcare providers caring for these people as well as patients can be a major contributor. So it's not just the patients not understanding their medications, it's also that potential risk of the wrong dose being provided to the patient, the wrong frequency being written on the bottle. So there's other issues besides just the patient and family's issues with the medication handling. So when we think about communication within faith community nursing, we know that a lot of what we do is communicate, and that's between the patient, the caregiver, the patient, and other members of the interpersonal, interprofessional team. And so when we look at these communication failures that happen that lead to people going back to the hospital, so there's repeat admissions, oftentimes we find that the communication related to medications is one of the major issues that happen. I know as a faith community nurse, something that I've seen on a regular basis is when the discharge instructions say, take this new medication twice a day. They get the medication filled, they bring the bottles home, they're exhausted, nobody from their family or anybody was there with them for the discharge instructions. Then they look at the new medication and they say, oh, I don't even take this. I don't know why they gave me this. And they put it on the counter and they intend to maybe ask their primary care doctor at the next appointment. And that next appointment may be a month away. And so they don't take the new medications because they don't remember that what they're for. And that's the most common barrier or communication issue that I've seen related to medications. And that's the patient goes home and they really don't know what to do with the medicine or what it's for. But part of what we do as faith community nurses is to educate our congregants on self-care. Yes, we want to include their primary care provider, their specialists, their family members, their caregivers, but we really need to focus our education on self-care when possible, so that they know the importance of not just setting that medication on the counter. For example, if it's a congestive heart failure patient and they set that medicine on the counter, oftentimes what you're going to find is that it was something such as a diuretic or something to make their heart, beat more strong and regular, and they don't take it. And so that's where the communication comes into play. Also, making sure that the primary care provider gets brought up to speed as quick as possible. What we find sometimes is that a congregant will be discharged and it takes 2 weeks to get in to see the primary care provider. And it's in that 2 week period of time that a lot of people end up back to the hospital. And so, as faith community nurses, we need to advocate for our patients by calling the primary care's office and saying, I know you don't have any regular scheduled appointments for 2 weeks, but I want to advocate for my patients. They're high risk for readmission. They were discharged 2 days ago, and we need some guidance from the provider. And so, oftentimes when you approach it such as that, they'll find a place that they can work the person in. So it's very much about the approach. And so another thing I wanted to say is as we're going through these slides, I pull out important and key things and give examples from my practice. I don't read the slides to you because I know that, just reading them, you can do that. So I want you to, anytime you want to, you can pause the recording, read the slide, and then restart the recording so that you can really benefit from both the written material on the slide and also my discussion from my practice and how it relates back to these issues. So one piece of the puzzle that we as faith community nurses encounter and we work with, we deal with on a more regular basis than probably any other area or specialty of nursing is the spiritual care piece. And, spiritual care is very much relational. It's, I don't know if any of you have been in a situation where you've been in a hospital setting, either with a critically ill loved one, a sick loved one, or you yourself have been sick, and the hospital chaplain comes around. You can find it very encouraging, very supportive. It's a wonderful service, but there's times where you feel so disconnected from that person that it's hard for you to truly engage in that spiritual support. It's much easier when it's someone that you have a pre-established relationship with. And so the spiritual care piece of what we do really does set us aside, set us apart from other specialty areas of nursing. So as I mentioned earlier, the self-care education is so important because people come home and they're exhausted, they have limited support, sometimes they have a lot of support, but we often go straight to that caregiver and start educating. And I know I'm guilty of it. And what happens is I look at the patient and I think they're so vulnerable, they're sick, they're the ones in need. And so I immediately jump to educating the family and the caregiver. And while that is very important and it's awesome that they have that support, we have to remember that research shows us that including these folks in their own self-care education has been shown to really improve outcomes because they're knowledgeable and they will advocate for themselves in the absence of someone else. And, when we're looking at the self-care piece, it really is going to be individualized. We have to go into the situation with each congregant completely different from any other congregant. You're never going to find a situation where the home life, the caregiver support, and all of that is the same in a situation, whether or not that person, is in the same faith community or not. All of those home situations are different. So we want to assess the situation before we make any type of intervention plans. We got to know what's going on, what's lacking, what's not lacking, and assessing for gaps in knowledge. I don't know about you, but there's times I'll go into a house and I'll meet with a congregant and a family member, and I'm like, they know as much as I do. It's amazing. Some people are so intuitive and so responsive to education. It's amazing. And you go to the next home and they can't even remember that they got the discharge instructions. And so you have to be prepared to be flexible in your approach based on the different needs of the people. So you educate based on their needs without just making a cookie cutter education plan that you use for all situations, because that's not going to be as effective. And again, just to reiterate, we really do have to build that rapport and that trust with the patient and the family so that when we do make that entrance into the situation, whether it be with the visit at the hospital the visit at discharge, follow-up visits, going with them to their primary care providers. It really is imperative that we help to build trust, knowing that that's going to be the most successful way we can reach these folks. So when we're looking at, again, the unique education plan for our different congregants and different families, we want to take into account something that's the most common but not always the case. Most commonly, the faith community nurse is a member of that particular faith community. So they're a member of that church or faith community, or their family. They feel like church family, faith community family. But there are faith community nurses that serve multiple churches, and they're only a member of one of the faith communities. And so if you are in that situation, you're going to have to approach it differently than if you are a member of the faith community where you're serving. So keep in mind, it is very possible, it's doable, people do it all the time. They provide care for people from different faith communities. But I also want you to wrap your brain around the fact that most of the time, the nurse is a member of that particular faith community. And, as far as the cultural competence, that does play in here. For example, my faith background is in Protestant, mainline Protestant evangelical. And while I'm familiar with, let's say, a Calvinistic background, okay, which would be a Presbyterian faith community, the cultural difference there in the teachings are somewhat different. And so my approach to the spiritual care would need to be grounded in my knowledge of their culture. Okay. So we have to be in tune to the cultural appropriateness. And, that's another area where I've had a lot of requests for faith community nurses over the years to do an educational program on the different faith backgrounds and to really improve our cultural sensitivity to the different faith traditions. And that may very well be our next step. But the transitional care course was the number one requested program so far. And, when we're looking again at those cultural differences, we have to be prepared to set aside our cultural beliefs and to embrace and to support those with different beliefs. So we talked about medication. We put that right up front because honestly, it's the number one reason why people end up going back to the hospital. So we wanted to get that, on the docket for sure. But chronic disease self-care, which, medication relates back to this. Chronic disease self-care is an issue of great concern because whether the patient has congestive heart failure, COPD, whether they have hypertension, whether they have diabetes, whatever their underlying chronic illness is, the approach to the care is going to have to be tailored based on those different disease processes. So the faith community nurse needs to be very knowledgeable about the different disease processes. And, that may even be another. As I go here, I'm thinking ahead, learning more and taking a refresher about the different common chronic diseases so that we can find out what's the current standard of care for these, what are the treatments, and, so we can get familiar with the different chronic diseases. But it is a major concern. And so the complexity of these chronic diseases is great, honestly, because rarely does a congregant who's been in the hospital, who's coming home, rarely do they have just one chronic disease. They usually have comorbid conditions, hypertension, diabetes, heart disease all together. And we really, this chronic disease self-care is where we see a lot of gaps between the discharge instructions and what actually happens at home. So again, this is an area that we have to hit hard early after discharge. So when we think about the fact that nursing in general and faith community nursing specifically is very much centered around advocacy, where we are advocates for people. And when we educate, it's with that in mind. We educate people because we can assess the gap in their knowledge or their skills, and we know from experience what can happen, which would be a readmission to the hospital or worse. So with the education piece, we have to really look at planning earlier in the process. And what I mean by that is, when you find out a congregate is in the hospital, you don't want to wait until you get the alert that they've been sent home to get involved. You want to get involved from the day that they are admitted if possible. Because the education you're going to do needs to be in alignment with the discharge plans that they receive when they leave the hospital. So you want to do a visit or two before they're discharged. You want to develop communication and rapport with the discharge planners, with the case managers. You want to follow that up with a home visit and education. And then you want to also continue with visiting their primary care provider with them if at all possible. And, and again, not just caregiver education, not just patient education, but the two of them combined is the most effective way to prevent readmission. It's important for us before we develop and implement an education plan to know the literacy level of the congregant and the caregiver. And so that's something that we would want to determine as early as possible. And we want to also continue to assess the patient and the caregiver's adherence to the treatment regimen. We don't want to go in, educate, and then dust our hands and walk away. We're going to, go in, see them in the hospital, see them at discharge, see them when they get home after discharge, try to go with them to their primary care provider. And you may want to do daily phone calls for the first week to say what's going on, what can I do to help, and just really assess where they are and what questions and concerns they may have. We know some of the common barriers to effective education are complex plans of care, also high stress level of the patient and the caregiver, if there's no caregiver involved, or lack of confidence by the patient and caregivers. They feel like they can't, educate. Those are things that we have to, as faith community nurses, really focus in on. So when checking feedback to evaluate comprehension and recall in your self-care education of these people, ask questions in a way that won't cause them to feel shame or feel like they're being tested. You might say, okay, so let's talk about your daily schedule. Tell me what all you did today. Instead of saying, did you check your weight? Did you check your blood pressure? Did you take your medicine? You want to get them to talk about what they've done and then redirect them as needed. So some examples of self-care patient outcomes, which we talked about, very critical to the transitioning piece. We want them to be able to identify and take appropriate actions if their symptoms get worse. What if they get shortness of breath? What if they get chest pain? What if they get swelling? So that's part of our goal in self-care education. We also want them to be able to describe the purpose of a specific medicine. And so we want to assess that they understand the reason for taking a medicine and, what side effects they might expect from that medication, etc. We want our patients to be able to demonstrate the ability to perform self-care activities and access help when needed. So we might say to them, what are you going to do if this happens? What are you going to do if you wake up and your swelling in your feet's much worse? So you run them through potential scenarios and get them critically thinking about their self-care. We want them to express confidence in asking doctors and providers questions about their diagnosis. So we want them to say, I'm going to make a list of questions and I'm taking it to the doctor with me. And we want our caregivers for our patients to be able to correctly describe the steps in managing an urgent situation with the patient, such as chest pain. So some of the examples of topics that you could really make yourself a to-do list and educate on in these homes are listed here to the right. Everything from managing symptoms to talking about chronic diseases and what to expect. So use this list as a guide to make yourself an education plan where you make sure you're covering all of your bases for your patient. So, as we mentioned earlier, the spiritual care piece of this is really, it's really such a unique part of what we do as faith community nurses. And spiritual care really, it's important that we meet the patient where they are in the spiritual care needs. So we don't, in our walk spiritually, we want to find out where they are and meet them there and encourage them and support them in the ways that they find beneficial to them, whether it's prayer with them, whether it's praying for them, whether it's sending the pastor in to meet with them. You want to meet them where their spiritual care needs are. And, you know, we as faith community nurses, a part of our training in the foundation course is on spiritual care. And so we have some training, but we really need more. You know, we really need more spiritual care training because we are expected and we're in a unique position where we're going to be offering a lot of spiritual care support. So I encourage you to continue to seek out learning opportunities that relate back to spiritual care. And, you know, when we think about spiritual aspects and, that are key contributors to help people perceive a health situation, for example, um, a patient who has a strong faith, who receives a diagnosis of cancer, may not respond in the same way that someone who has less faith or less spiritually supported might respond. And we have to be aware of that. And the faith community nurse really should incorporate spiritual care in every area of the care plan. It shouldn't be its own separate situation. It should be a part of the relationship between the patient and the caregiver and all people involved. So you don't want to isolate spiritual care to its own separate activity. You want to integrate spiritual care all throughout the plan that you have to support this congregate. So advocating to other providers the recognition of spiritual concerns will support a more comprehensive transitional care. For example, when you go to the primary care provider with the patient, you might say, Dr. So-and-so, I wanted to let you know that your patient and my patient, Mrs. I'm going to use Mrs. Smith, has recently been baptized, and this has brought her great comfort. So you want to make sure that other providers are also aware of that spiritual care piece of the care that's being provided. So, word of warning, okay? Because of pressures in these healthcare settings, okay, to get people out, get them out quicker, keep them out, okay? Raise the quality while cutting the cost. We know faith community nurses and healthcare leaders may be tempted to focus mainly on the physical issues, but we should not negate the spiritual care needs, the mental health needs, the emotional, the psychological, the psychosocial. So be a leader in that piece. Just because the physical needs are of great importance, we have to keep those other aspects very much actively and involved and alive in the care that we provide. So faith community nurses that can be affected by this pressure, okay, of focusing on physical, not spiritual, they really would be ignoring an area of care that research shows is vital to effective care. So we want to make sure that we are looking at this from a holistic standpoint. And you know, the same error though we could see if we only focus on the spiritual. And so we have to make this a combination of spiritual, psychosocial, psychological, mental health, physical, a package of care for our patients, because we really do help to bridge the gap for these patients and their spiritual care. So when we're thinking about critical contact, okay, times that are the most critical, we've already talked about getting in there and seeing that patient before they're discharged. Making sure that you're seeing that patient in the hospital before they're discharged. That would be a critical visit. Okay. Implementing timely and appropriate transitional care, starting before they go home from the hospital and following that person home. And so you want to start those hospital visits, of course, those transitional care visits before discharge. And it's important for us as faith community nurses to build rapport not only with the patient and caregiver, but also with the staff within the facility that they're leaving. That may be the nurse that's been taking care of them on the floor. That may be the case managers. That may be members of the medical team. We want to be as visible as possible, letting them know we are a part of this team and that we will be helping this person transition to home, hopefully successfully, without having to come back to the hospital. And so if this person, this congregant, this patient has been someone who's come back to the hospital recently, that's a part of what we want to know is why did that happen? Because that's a good place to start. If it was because of a fall in the home, that's a good place to start. If it's because of a medication issue, a good place to start. So we want to know these things about our congregants. And, you know, the home visits are really an effective strategy for cutting back or reducing the times they go back to the hospital. So going into the home, doing an assessment, starting that education plan, doing phone call follow-ups, doing repeat visits to the home are all a part of that process. And really the faith community nurse should be prepared to do home visits as an essential intervention for transitional care. So we need, if at all possible, to make sure that home visits are a part of what we do. And, you know, we know that from the research, evidence is showing us that home visits do work. Okay. They do work with, especially during that immediate discharge, 7 days or so after discharge, getting those home visits, getting that education going, assessing the patient's needs, assessing the home environment have all been shown to be effective. And, you know, these home visits that we do as faith community nurses um, really tend to focus on chronic conditions, especially that first visit. We want to know how they're managing their COPD, how they're managing their heart disease, and, you know, to try to keep them from having to go back to the hospital. And, you know, when we're looking at some vital interventions that we can do that have been shown to cut back the number of readmissions, making sure that the primary care provider, that there's a follow-up schedule and transportation has been laid out. Okay. Starting that self-care education, especially about priorities with their disease, reviewing and reconciling medication lists, reviewing discharge instructions and talking to them about those instructions again, establishing a plan of care, and then keeping records, documenting all of this and through the process that we see. And I think we would all agree that we have congregants or patients who are high risk and we have some that are not. Okay. Some of our not high risk patients are the ones that come in after, you know, being in the hospital. They know their medicines, they've got their care lined out, they're getting up every day, and, you know, we still need to support them, but they're not as high risk. But if you have a congregant that goes home, they have limited support at home, they've been in and out of the hospital a lot, they've got multiple new medications, you're going to find that these patients oftentimes are the ones that are most likely to end up back in the hospital. So we may need more frequent visits, more support, more phone calls to improve that piece. And, you know, when we're thinking about the avoidance of a readmission, it's the 30 days post-discharge that we see the most number of people going back to the hospital. So we want to really focus, especially those first 30 days after discharge, on this whole process of care and transitions, because this is really a critical time to do these things. So the nurse is held to the application of good clinical judgment, okay? And we know that. And so we have to decide based on our assessment how many visits we should be doing, intensity of these interventions, how long they're going to last, what all do we need to accomplish, the evaluation of how the patient responds to these interventions, and the point at which whole visits can be cut back or replaced with another form, such as phone calls, emails, text messages. We have to use our good clinical judgment to decide when this time is ready, when we're ready for this. So the primary care providers, we talked about the fact that this is a critical point that we have to help bridge that gap between the patient getting home and that first primary care provider visit. And so that first visit really needs to be as quick as possible, as seamless as possible, with good support, and making sure there's a list of questions ready for that primary care provider. Making sure that the other people, the other caregivers are involved in that and understand the situation. And, we're going to talk a little bit about the HIPAA piece as well, because HIPAA does play into this. And again, if possible, the FACE community nurse does need to go to that visit with the primary care provider and the patient. And making sure that those visits are structured, organized, you've got your questions, the congregant has their questions, and you get those answered during that visit. So what can we do to prepare our patient and caregiver for that visit? We want to talk about transportation. How are they going to get there? How are they going to get anywhere to appointment? Okay. We want to make sure they have their paperwork and any records that they need to take with them need to be all gathered up and ready. We want the medication list to be organized so that we can discuss that with the primary care provider. We want the patient and caregiver to write down questions, as well as the FACE community nurse to write down questions. And we want to encourage and promote comfort in the congregant and the caregiver talking with the primary care provider, making sure that they have a voice and can get their questions answered. Not just you get your questions answered. You want them to be able to comfortably communicate with the PCP. So here's a list of some tips that you can review for that first visit or ongoing visits with the primary care provider. We want to make sure, in summary, that the PCP knows what the discharge instructions say. Okay. We want to update them on how things are going, update the primary care provider. And we want to review and compare the medication list between what we have as the discharge instructions and what the primary care provider has, making sure that those are addressed. So the FACE community nurse should assist the patient and caregiver to really get these activities by the end of the visit. Okay. You want to know what is the after-hour contact info for the primary care provider. You want to know, how can you and the patient get in touch with them? Help them schedule their next appointment. Make sure that the medication list matches up, and get a copy of the treatment plan from that day to put in the patient's file at home. And, usually those phone calls, those follow-up phone calls are an important piece of what we do as well. And, calls they take less time. They don't require the transportation. They don't require the gas and the mileage on the car and all of that. But you still have to use good clinical judgment to decide when is the time to do that versus when is the time to make a visit. So you want to use your good, sound judgment on that. And you want to make sure that the access to care, is maintained, whether it's by phone or by in-person contact. So recommendations for these follow-up calls, you want to focus on any new problems. You want to talk about the old problems and also talk about new problems. You want to talk about their medicine. How is that going? How are they managing their medication? Okay, talk about signs and symptoms that they should report immediately. You want to read that primary care provider visit notes with the patient again to make sure you both are on the same page. You want to assess the use and access to other services in the community, such as Meals on Wheels or transport systems. And also consider further follow-up calls with caregivers alone or with the patient as needed. So these are all parts of your planning for your follow-up calls. And as space community nurses, we have to really hone our communication skills. We want our patients to use teachback so we know that what we're saying to them is clicking. Follow-up calls, making sure that they can tell you their current situation. And it really does improve and cut back on the rate of transition failure, which would be back in the hospital. And, we've all been trained for at least 20 years now on HIPAA. And the FACE community nurse is accountable to protect and maintain patient information. And we have to follow through with that. So in person, patients can give us permission to be at the bedside with the primary care. So the patient can say, yes, I want you here. Over the phone, or if you want to share your blood pressure record with the doctor, or you want the primary care provider's notes, you're going to have to use authorizations for release of information, just like you would see in any other setting. Okay, so keep in mind that you will need some form of permission, authorization to be able to share records and so forth. So when we think about care coordination, we know that a lot of what we already have talked about in this presentation is care coordination. Whether it be going to the hospital, going to the home, phone calls, going to a primary care provider's visit, these really are centered around care coordination. And we have to, as space community nurses, be very proactive in our coordination. We can't just say, oh, well, let me know if you need anything. They won't. Okay. Now, you can say that, but that doesn't mean that you shouldn't continue to follow up. Okay. Really, when you look at care coordination, it really is the cornerstone of transitional care. It is the advocacy role. It is the education role. It is the spiritual support role. Care coordination is making sure that all things have lined up to get them where they need to be and when they need to be there for ongoing care and support. So optimal meaning the best it can be, optimal management of the coordination during this transition of patients includes really building collaboration and support between the patient, the caregiver, and whatever provider you're helping with, whether it be their primary care provider, whatever that process may be. So when we're looking at building relationships and we're looking at advocacy and we're looking at those frequent calls, all of this makes up a picture of excellence in the care that we provide. And, we really do, when you look at the big picture of FACE community nursing, we really have an advantage for transitioning our patients that other transitional care models lack. Okay, relationships, access, supportive, we can encourage and guide them through the resources that they need. And for the first primary care visit, we want to make every effort to go with that patient, and we've talked about this, and assess the needs of that particular patient. Here's a list of suggestions for proactive preparation. I want you to read through these and really consider for this week's discussion post how you will integrate and use these. So feel free to pause the recording and jot down some ideas for how you will be proactive in preparing for care coordination. Okay. So finally, we get to the resource coordination, and this really is one near and dear to my heart because I think having a list of resources can really make a difference for our congregants. We want to know who are the food pantries, who are the soup kitchens, who are the transportation programs, who are the Meals on Wheels, where is the community center for elderly. So having a list of resources for your particular service area for your congregants is going to do more for them than you'd ever imagine. So I encourage you to build a list of resources, keep that list updated and current, add to it, take off stuff that's no longer relevant. Okay. And coordinating of this process really is something that falls under what we do as well. So making sure that we have those lists, that we share those lists, and that we incorporate other people in that care. And finally, let's remember our caregivers. We have to encourage them. Caregiver role strain is a common diagnosis in transitional care because they get burned out, they get exhausted. And so we have to find unique ways to continue to engage them in their self-care and support them however possible. So thank you so much for your time today in this presentation. I look forward to the ongoing dialogue on the discussion board, and please feel free to reach out to me with any questions. Thank you.